started with joints. Okay, so what are we going to cover today? We need to know classification of joints because it's anatomy class and we like to classify things. Okay, so that's first. Then we're going to zoom in and look at the synovial joint and look at a couple of examples of synovial joints. Then we'll look at types of movements made possible by joints. And in this part of the class, you guys will be my active guinea pig volunteers. Okay, so we're going to look at what our movements are called. And then we'll finish up with homeostatic imbalances. What can go wrong with joints over time? Okay? Here we go. So, we have to classify them. The first way we classify joints is relative to their freedom of movement. Okay, so some joints can move all over the place, whereas some joints don't move at all. It's just where two bones hit each other. Two bones sit beside each other. Okay? So, diarthroses, or diarthrotic joints, are freely movable. Okay? So you can move them all over the place. So what is an example of a joint that is a diarthrosis? Your thumb, yes. Your thumb is freely movable. So that is an example of a diarthrotic joint. Okay? Anybody think of another one? Your head. Yes. Okay, so, well, let's more specific. Let's say it's your neck. Right? Okay. Because we're going to get to head area in a second. Okay. So, diarthrotic, multiple, freely movable. Okay, then we get to amphiarthroses, or amphiarthrotic joints. These guys are slightly movable. So, what do you know about amphibians? Because you know I like to incorporate our zoology references into class, right? So, what do you know about amphibians? They what? They like to live in the water and only they're a little bit of both, right? They spend time in both places. So amphiarthrotic is in the middle. He's a little bit like the diarthrotic joints, and he's a little bit like the synarthrotic joints. He's in between. Okay, so he's slightly movable. All right. So a joint that is slightly movable. Yeah.
Your elbow?
Elbow's pretty movable. He's a
It
diarthrotic.
only goes one way though. It can't go this way.
Yeah, but he's still more movable than these joints are. Your spinal column. Okay, so your spinal column or your vertebrae are this type. There's another example, but we'll get to it in a second. Guys, do you like my technology? Okay, it only has 5% battery left, though, so it's only going to last for like 2 more minutes. All right, and then the last one is synarthroses or synarthrotic joints. They are immovable. So, what's an example of where you have two bones that are sitting beside each other, but they don't move? Your sutures in your head. Okay, so your skull bones sit beside each other, but they don't move. Right? Isn't that a good thing? Okay. So, we have joints that don't move. Isn't that crazy? Everything you know about joints is just all out the window. Okay. So, that's the first way we classify them, is how they move. Now, we also classify them structurally. So how do the two bones join together? These are rocket science. You ready? Fibrous joints are held together by fibers. Cartilaginous joints are held together by, and synovial joints have a synovial fluid. Yeah, and a synovial joint, or synovial cavity. Okay, so these are pretty straightforward, right? Their definitions match what they're called. Just to point out, the fibrous joints, the fibers that are holding them together are collagen fibers, which we know is all about strength, right? All right, so let's look at a couple of these examples. They're going to be examples categorized by structure, but the structure and the function, remember, are related. So we're also going to be able to tell their freedom of motion. Okay, so here we go. First group, the fibrous joints. So we have collagen fibers holding them together. example number 1 are your sutures. So the sutures are held together by tiny collagen fibers, little tiny guys. Okay? If our fibers get, suture joints are only found in the skull, by the way. Okay. Next guy. Semidesmosis is another type of joint. You're still having collagen fibers holding you together, but they're longer now. Okay? So they're not really tiny collagen fibers. We see these in multiple places in the body. An example would be at the distal end of the tibia and fibula. We have a little area of collagen fibers that are holding the two together. Okay. And our final example of a fibrous joint is a gomphosis. Isn't that a fun word? Again, gomphosis joints are only found in one place in the body. They are the joints that hold your teeth into your skull. That is a joint, guys, because it's where two bones are meet each other. It's crazy, right? Everything you know about joints is all out the window now. Okay, so it's a peg and socket joint. There's little collagen fibers all along here that hold that tooth into the socket. Okay, all these joints that we looked at do not move, right? Unless your tooth is falling out. But then that means that the joint, those collagen fibers are broken down, right? Okay. So these don't move, so they are considered synarthrotic. All right, so those are fibrous joints. Next are the cartilaginous joints held together by cartilage. So do you guys remember talking about the epiphysis and the diaphysis and the growth of long bones that happens there at the epiphyseal plate? And we said that at that time while the bone is growing, we have two different bones, well, three different bones in one bone, right? So the two epiphyses and that diaphysis. So there's three different bones. And there is cartilage between the epiphysis and the diaphysis. So it is a cartilaginous joint. Cool stuff, right? So there is a joint right there between the diaphysis and the epiphysis. Okay? We also see this joint between the first rib and the sternum. So those costal cartilages that hold the ribs to the sternum, those are cartilaginous joints. Okay? These joints that are made of hyaline cartilage are called synchondroses. See, I told you it was going back. And they are synarthrotic. Okay? So they don't really move. But it's good, because you don't want your epiphysis to move off your diaphysis. Okay, but then we also have cartilaginous joints that are made out of fibrocartilage. Where do you find fibrocartilage? In your vertebrae and in your pubic symphysis, okay? They're made to withstand lots of shock, and they allow some movement, so they are amphiarthrotic. When does this pubic symphysis move? I heard somebody say it, but really quietly. Childbirth, right, when you got to push something out of that opening. That opening sometimes isn't big enough, and you got to push it, okay? So, amphiarthrotic. Now, we talked about fibrous joints. We talked about cartilaginous joints. Now, we are going to spend almost the rest of the class talking about synovial joints, okay? Now, it doesn't tell us, there isn't a, sorry, I'm trying to get my phone connected, but it doesn't tell us what type of functional category these synovial joints fit into. This isn't going to work. I'm just going to do it. But these synovial joints are examples, are shoulders, knees, hips. So what type of functional category do you think they fit into? Syn, di, or amphi? Diarthritic, right. So they're freely movable. So synovial joints are diarthritic. Okay? So what makes the synovial joint special? The bones are separated by a joint cavity that contains synovial fluid. Okay, so there's a little opening in there. The adjoining surfaces of the bones, so the end of one bone, the end of the other, are covered with hyaline cartilage that reduces the friction. So if you've got two bones rubbing up against each other, we want to do everything we can to make it glide smoothly. So the fluid helps, and we also have that smooth hyaline cartilage there that helps as well. If you start breaking down the cartilage, you can begin breaking down the bone as well. Okay, so we need that cartilage to be good. We also have a joint capsule around the outside that helps give structure and support to that synovial joint. So we want these joints to be movable, right? We want things to move everywhere around, but we want them to be movable within restraint, right? If joints move the way they're not supposed to, that's when we have tearing of different ligaments. That's when we have joints coming out of location, so they pop out. So we have to have that strong joint capsule to help hold everything together. Okay, and we talked about some examples. Okay, general structure of the joint. This is an objective, and you're probably going to see this picture on the text, okay? So, some parts. What's important? Here in the green color, this greeny yellow, that is your joint cavity where the synovial fluid's going to be, okay? So it helps lubricate, keep things moving good. At the ends of the bones, that's covered by your articular cartilage, which is hyaline cartilage, protects the bones. Then we have the articular capsule, and it's just the outside layer here that is covering the outside of the joint. Okay, it's made up of two layers. So the articular capsule has two layers itself. The most superficial, the one on the surface, is the fibrous layer, so it's the most outside right here. It's made of dense, irregular connective tissue. So what's that going to do for that joint? Right, it's going to withstand stretching in multiple directions. Okay, so it's going to give it a nice, solid, strong outside. Then underneath the fibrous layer is a layer of loose connective tissue, the synovial membrane. And his job is to secrete the synovial fluid. Okay? So both layers are really important, okay, and they both make up that articular capsule. Then, outside of that articular capsule, you're going to find ligaments and tendons and all wrapping around that joint capsule as well. There are also some times where ligaments are inside of the joint cavity as well. Okay. I've got one more slide of some other things that may be in a synovial joint. A meniscus. So a meniscus is made up of fibrocartilage. What does fibrocartilage do? What's the purpose of it? Withstands shock. So we're giving extra padding inside of that joint that's going to help withstand shock. So you see it in the knee. There's a lateral meniscus and a medial meniscus, and it sits between the two bones, and it just gives it extra cushioning and support there where the two bones meet. Okay? I've already said this, but it's reinforced both on the outside by tendons and ligaments, and sometimes on the inside by I guess not tendons, but by ligaments as well. Okay? So, on our knee, we have outside ligaments, so the fibular collateral ligament and the tibial collateral ligament line along the outside, and then your ACL and your PCL, the anterior cruciate ligament, posterior cruciate ligament, line here inside the joint capsule. Yes? No. Thank you for saying that. So, we're going to get into some pictures like this of knees and shoulders and things like that. You don't have to know the specific examples. You just need to know the general examples. Okay? So that general figure we looked at. is what you need to know. I just threw this picture in there so we can kind of see what's going on. Let's talk about the different parts. Okay. Does anybody know what the word cruciate means? What shape it's talking about? Yeah. Is it like a what? Not a crescent. Good guess though, because that's what it starts with. A cross. Yeah. So cruciate, crucifix, the same prefix. So the anterior cruciate ligament and the posterior cruciate ligament, they form a cross here in the middle. Yeah.
So for one of our objectives, it talks about the knee joint specifically. Do you have to know those ligaments and where they are?
No. Okay. So what you need to know about the knee joint, we'll get to in a second, but you don't have to know the actual picture. No. Okay. All right. The last thing on this slide is a bursa. So a bursa is a fluid-filled sac. It's filled with synovial fluid. And it kind of works as ball bearings. It sits there, and then the ligaments and tendons and muscles can roll across the top of it. So it rolls with it, okay? So it just, again, produces friction there in the joint cavity, okay? I'm going to show you a picture of a bursa with our first example. So again, this is just as an example to show you what a synovial joint looks like. We are going to try to find those general things in a specific example, okay? So this is your shoulder joint. I was asked by somebody what the name of this specific joint was while y'all were drawing. And I said I didn't remember, and then it hit me right after class. Is that anybody? It's a shoulder joint? Yes, it's a shoulder joint, but he has a specific name, okay? So, what bone is this guy right here? The humerus. What bone is this guy right here? Scapula. What's the bone marking right here? What's the socket that the head of the humerus fits into? The glenoid cavity. So this joint specifically is the glenohumeral joint. Okay? All right. So the glenohumeral joint. We have a joint cavity with synovial fluid. What's this blue that's covering the ends of both of those bones? Hyaline cartilage, or articular cartilage, there on the sides. We have a bursa up here. Okay, so a little synovial fluid-filled package. If we zoom in, we can kind of see how it works. So this is your humerus, and if we, what does it say we're doing? Okay, we're abducting. So we're lifting the arm up like this, and as we do that, I guess I should lift this one up because it matches the picture. As we do that, this ligament needs to slide. And so there's a bursa in here that will roll as the bone moves to help reduce the friction of that bone rubbing against the ligament. Okay, so just little packages that help reduce friction. Okay? We've got our fibrous layer of our articular capsule here on the outside. We have our synovial layer underneath it. Okay? And another thing that you see here in the shoulder joint is a tendon sheath. So it's kind of like a bursa that wraps around the tendon. Okay, so it's another synovial fluid-filled package that wraps around there. Okay? So, shoulder joint, then, if we go back, or zoom out a little bit more, look at it more superficially, and we've put some of the ligaments and tendons back on, we can see that we have wrapped this glenohumeral joint with some really strong ligaments, okay? And so they're wrapping around and helping hold that shoulder joint in place. Okay, so even outside of that joint cavity and that fibrous capsule, we also have lots of ligaments there that are helping hold it in place. Okay, now we're going to compare this to the hip joint that we're going to get to in a little bit. Okay, range of motion. If you look at the shoulder joint, how much movement do you have in the shoulder? A lot, like you can go all over the place, right? Okay, so we have lots of movement in the shoulder joint, but what we sacrifice to get to that range of motion is some stability, okay? So to our femur that we're going to get to in a little bit, into the acetabulum. Okay, so the glandular cavity is a little shallow with our humerus sitting in there. And we've got some ligaments around there to protect it. But he's not as protected as your hip joint. So it's fairly common in injuries to see your shoulder joint pop out of socket, right? Because there's just less protection there at that shoulder. But you get more flexibility. So it's a trade-off. Okay. The knee joint, again, don't worry about memorizing what's going on here. We just want to say that this is a synovial joint, so it has some of the characteristics. Okay, so we've already talked about our ligaments inside, our ligaments outside. We have our medial and lateral meniscus here. Okay. So we've already kind of looked at that picture. Let's go on to this guy. We can see a little bit more on this one. Okay, so you can see the cruciate ligaments, how they crisscross on the inside there. What's this blue right here? Articular cartilage. Okay, what are these green sacs? Bursas, right. Okay, so we've got 3 right here that we can see. We've got the suprapatella, we've got the subcutaneous prepatellar, and we've got the deep infrapatellar bursa. Okay, so these pads, or these bursa, can become inflamed. Yeah.
So what happens if the bursa?
Yes, that can happen. So if you injure it and you squish it too much, it's like any type of sac, it can burst, and that synovial fluid will leak out. If it is a bad enough burst, it may not replace itself. But if you are a young person and it has burst, it can probably grow back, repair, fill itself back in, and then start producing more synovial fluid. So eventually, it'll get back to where it was before. Yeah.
When you talk about joint fluid, with which kind of fluid?
So it depends. So the joint fluid, just normal joint fluid, is a synovial fluid that's sitting in that pocket. Things can happen, though, to add more fluid to the area. So inflammation of that joint can cause fluid to fill up the synovial cavity. That can cause problems and make it hard to move. There's something else that can happen to the bursa. Does anybody know what else can happen to the bursa? Not exploding it or not bursting it, but if it gets inflamed, what's it called? Bursitis. Okay, so bursitis is inflamed bursa. So there is some type of immune response going on there, which will cause swelling in the bursa region. Okay, more fluid in that area. All right. So again, just seeing that those common components are here in the knee as well. Yeah. Yeah. Uh-huh. So the bursa is less about protection, more about making sure the skin on the surface will slide easily over your patella. I mean, it depends on what you're doing. Yeah, if you're on your knees, if you're praying a lot. But yeah, you could do it. Or if so, there was a question that we had in here that they took out of our lecture for this year. But last year we asked the question for the students to work on that said, a lady is a house cleaner and is frequently getting up and down from her knees to clean things on the floor, and then later has issues with knee pain, bursitis of that subcutaneous patellar. That's what it was. Yeah. So it depends on what activity you do, is what injuries you get. Yeah.
So when fluid gets in those joints, is that why people have to get their knees drained?
Yeah. Yeah, it is gross. But it helps. Because it reduces the pressure in the area. Because these joints have lots and lots of nerve endings in them, because your brain wants to know what your joint is doing at all times, because it helps with movement. But because there's lots of nerve endings there, when there's damage to that area or when there's fluid in that area, it can really be extremely painful. All right, if we zoom out even farther, we can see now how a muscle plays a role. Okay, so we still have our ligaments, but now we're adding tendons from our muscles, and we've got our big quadriceps up there at the top. Okay, so the health of a joint depends not only on that small fibrous capsule, it depends on the ligaments in the area that are holding the bones together, and it depends on the tendons in the area that are holding the bone to the muscle, and it depends on the strength of the muscle itself. So strengthening muscles around a joint can also help give strength to that joint as well to prevent injuries and things like that. Okay, so it all works together. All right. Let's talk knee injuries. Any of y'all, I guess it's hockey. Any of y'all hockey players? Have you ever had this happen to you? No, good. Good. Okay. So the example is hockey here, where there's a puck flying at you really fast and hitting you right at that knee joint on the lateral side. Extremely painful. But injuries like this can happen in many activities, right? Anytime where there's a force on that joint that's going to push it in a direction that that joint doesn't want to move, right? That joint is designed to do this. Any way you hit it that's going to make it go another way than just this is going to hurt. So hitting it from this side, hitting it from this side, and hitting it from the front and pushing it backwards, all would be a problem, okay? So, in this example, we hit it from the lateral side. Now, notice that our ligament over here on this side, our lateral ligament, mostly stays where it is. I mean, there's going to be a lot of bruising, and there's going to be issues over here. But where do we see the most problems? Over here on the other side, right? Because when this joint is pushed this direction, these guys are going to go plop, right? In this example, we have actual tearing and complete tears of our ligaments. So our tibial collateral ligament that's supposed to run along the side has been torn in half and broken completely. Our ACL has been broken completely, and we have also torn our meniscus over on that side. Okay, so pretty bad injury with ligaments. You can sew them. You can sew them together. That will kind of hold them together while they heal, but they take a long time to heal. They can also take ligaments from other areas and put them into that location to help kind of fill in and help repair the area as well. For a meniscus, again, they can go in and sew it together, but meniscuses don't heal quite as easily as even your ligaments do. It's even worse. Okay. Now, if this injury would have come from the opposite direction, so let's say somebody hit them from the medial side, where would we be seeing damage? On the lateral side. Yeah. So it's just the opposite side of where the force comes from. Yes.
Is there any injury like this that you can like get away with not being?
Yeah, so it depends on how severe the tear is. If you've got a tear where it's flopping off like this, you're probably eventually going to have surgery to line the pieces up where they'll be close enough to heal. If it is a less severe tear, there are instances where they just wait and see to see if it will heal itself back up. You haven't had surgery yet, have you?
No, but that's because I'm at college.
Okay.
I was supposed to.
You were supposed to.
Yeah, I'm having it today.
Okay. The good news is we heal slowly.
My dad's kid.
So it's not like a bone where if you don't set it, it's going to grow back into the wrong place and then you have to re-break it. So that's good. That's good. Okay. So knee injuries. All right. Moving on to the hip. So what bone is this? Femur. Okay, this joint's going to be made up of the head of the femur and what bone marking over here? Acetabulum or acetabulum, whichever way you want to say it. Okay, the acetabulum is a much deeper hole that you're going to fit the head of that femur into. We've got plenty of ligaments surrounding here. So this joint is structurally more sound, but what do you know about the range of motion of a hip? It's a little bit less than your shoulder, right? You're not able to go all over the place with your leg. Okay, but again, we can see that it has all the parts that we talked about. Again, you don't need to know it, just it's an example. Okay? All right. Moving along quickly. All right, again, this is not something that you are required to know. This is just to show you that although all these joints are synovial joints, different synovial joints have different ranges of motion. Okay? So for example, I'm not going to go through all of these, but there's a planar joint between your carpals. How much movement is there between your carpals? There's some, right? Because your carpals are right here in your wrist, lower hand area. There's some movement in there. Okay, you can kind of move your hand like this. But you don't have a full range of rotation right here in this part of your hand, right? So those joints are synovial joints, but they're called planar joints, where you can move in two directions. So you can slide across each other this way and this way, okay? A hinge joint is in your elbow. What range of motion do you have there at your hinge joint? Like a hinge, right? Okay, so hinge joint. A pivot joint between your radius and ulna, they pivot on one another. A condylar joint, you're going to have biaxial movement, so in two different planes. So if you go side to side, front and back. A saddle joint is at your thumb. And a ball and socket. Ball and socket is going to give you the biggest range of motion, right? All over the place. When I think of ball and socket joints, I think of having a sucker in my mouth. Do you guys do that? You put your sucker in your mouth and you swirl it around? The ball and socket joint. All right. Yes? Okay, so double jointedness, what happens is those ligaments and tendons that surround the joint are just more flexible. So instead of keeping you exactly where you're supposed to be, this is some more wiggle room. Yeah. Okay, yeah.
So what happens if you crack your knuckles?
So I've heard a couple different things, but I have to tell you honestly, I do not know the exact answer because I've heard of multiple things that explain why it is.
What about like cracking your neck or any other kind of?
Yeah, so do you want to look up and tell us definitively of all the different answers there are? So find a good source and tell us what happens when you pop joints. Like you pop your knuckles, pop your neck, pop your back. What does that sound? Okay, so some things I've heard is that it's just the bones sliding against each other. Okay, so it just goes click as it pops past each other. I've heard there's air pockets in there that are clicking. So there's lots of different things that I've heard. I don't know what the right answer is, so you're going to find it for us. All right, this slide in here, we're not going to look at it, but if you are interested in watching some joint surgeries, go look. It's fun. Okay, how much time do I have? So, joints as levers. So those are our joints. That's how we classify them. That's how they do what they do. Now, this next section, we are going to talk about this now, and then it'll be on your exam 3. So it's not on this exam, it's on exam 3. I think it may still be listed as an objective for this chapter, but it's not going to be on this test. Okay, so you can just move that objective to next class, next exam. Okay, so a lever. When you hear the word lever, you learned about them in elementary school. What do you think of? A teeter-totter. Okay, a teeter-totter is a lever. All levers have a fulcrum and then a load, something you're trying to move, and an effort, something that you're going to use to move the load, some type of force. When we use this in relation to joints. We say that a lever is an elongated rigid object. So in the joint, what's going to be our elongated rigid object? The bone, okay? So the bone is the lever that rotates around a fixed point called the fulcrum. What's going to be our fulcrum? The joint. Okay, so the fulcrum is the joint, the bone is the lever. And we are going to move it. Usually the load that we're moving, we're working against gravity. Or if it's your hands, the load is whatever you're trying to pick up and move. And the effort, what's going to give us the force to move the load? Muscle. See? It all comes together. Isn't it great? Okay. Now, it also tells us that the function of the lever is to confer a mechanical advantage. So it's to make our effort better than what it was without the lever. Okay? So it makes our muscles work better than it would without it. Okay, so we need joints. We need levers. There are 3 classes of levers. Class 1, Class 2, and Class 3, or first class, second class, and third class. First class is what you guys told me. The fulcrum is in the middle. You got the load on one side, and the effort is on the opposite. It's like the seesaw. Okay? An example of this in your body is the joint at the bottom of your skull and your atlas. So, that goes up and down, nod your head. The load that we're trying to pull against is gravity, pulling your head down. And our effort is going to be a neck muscle that pulls it back up. The fulcrum is that joint there between the occipital bone and your atlas. What bone marking on your occipital bone comes in contact with your atlas? Occipital condyles. And what bone marking on the atlas holds those occipital condyles? Superior? Articular? Facet. You guys had it, right? Okay. So that is the joint, that's the fulcrum. And you move the load with the effort. Cool? Cool. Okay, second one. So second and third class levers both move the fulcrum over to the side, but what is left on the other end is in alphabetical order. So in a second class lever, what's on the end is the effort. In a third class lever, what's on the end is the load. Okay? That may help you remember which one's which. So an example of a second class lever is a wheelbarrow. We've got the fulcrum touching the ground. The load is what you're carrying in your wheelbarrow, and your effort is your arms pulling up on the wheelbarrow. Okay? Example of this in the human body, and this just blows my mind, okay, is when you stand up on your tippy toes. Okay? The fulcrum is this joint at the balls of your toes, the ball of your feet, okay? The load is gravity pulling down your body. That's what you're trying to pull up. And the effort, what pulls you up, is your gastrocnemius and soleus, the muscles back here on the back of your leg. So the contraction of those muscles pull your body up. It's weird. It's like, never mind. We're not going to go down a rabbit trail. I'm out of time. We need to get through this PowerPoint. Okay, and then the third class lever, the load is on the end. So an example is a biceps curl. Okay? The fulcrum is your elbow. The effort is your biceps pulling, but it's stuck into here. So it's pulling right here. And it's pulling up the load, which is the weight on the other end. Okay, again, not on this test, but we wanted to hit it once because it relates to joints, and it's in this section of the book. But we'll come back to it later. All right, now, range of motion is the amount of movement a particular joint can do. Tends to decrease as you age. You get loss of flexibility because your joints aren't as flexible as they used to be. So again, to help this out, keep your muscles strong, keep moving, good nutrition, and you will make it better. Okay, now, stuff that is on your test. Types of movement. If you will stand up, please. And you guys are going to do some movement. Because on the test, we will describe a scenario, and you'll have to tell us what type of motion it is. Okay, so we'll start with the easy ones, flexion and extension. So when we do this, flexion is decreasing the angle between the two bones. Extension is increasing the angle between the two bones. Okay, so your head. If you flex your head, you are going to put it down like you are praying. So you're flexing your praying muscles. And then now extend your head. Okay, so extending is straight up, and then hyperextension is back farther. Okay, good. Okay, now with your vertebral column. Okay, so flex your vertebrae, extend it, hyperextend it. Okay. Okay, now your arms. Okay, so we're looking at shoulder joint now. Shoulder joint. Flex your shoulder joint. Extend it, back to normal, and then hyperextend. Back, good. Okay, and then elbow flex, extend, hyperextend? Yeah, we can't really hyperextend your elbows. It would hurt if you didn't. All right, and, okay, legs, legs. Okay, so we're first going to look at your hip joint right here. Okay, so if you flex your hip and keep your knees straight, which direction is your leg going to go? Forward. Yeah, so that is flexion of your hip joint. Extension is going to return it to normal, and then hyperextension back behind you. Now your knee goes the opposite direction. So if you flex your knee, it goes back. And then extend it. Hyperextension. No, you can't. Okay. Okay, so some of our joints prevent you from being able to move every direction. Okay. I think that was all of those. Now, next slide. Okay, abduction and adduction. What do you think of when you hear the word abducted? Taken away by the aliens. Where are the aliens? Up in the sky. Okay, so abduction is going away from your center line. So abducting your arms. What about abducting your legs? Let's abduct our arms and legs at the same time. Okay? Now, we're going to adduct. And adduct, you're adding back to your body. So abduct, and then adduct. Back to normal. Go. Okay. Huh?
Do they go up?
Okay. Adduct or abduct, you're just going away from the middle. But if you were being abducted, yes. Okay. All right, rotation. If we're talking about just the head, we can't say lateral or medial rotation because it's just rotation. So we rotate. If we're talking about legs, a lateral rotation, we're going to take our toes and point them out. Medial rotation, we'll take our toes and point them back in. Okay? Now, elevation and depression. Elevate your shoulders. Depress your shoulders. Okay. We can also elevate and depress our mandibles. Okay? So, depress your mandible. Elevate it. Depress. Elevate. All right. Another one. So this one's one that I feel like we have the most problems with is supination and pronation. Okay? So in anatomic position, your hands are front. This is also called the supine position, if you wanted to know. Okay, but to supinate, you are rotating to where your palms are forwards. So you can think of it like you're carrying a bowl of soup. So supination, you have to carry your bowl of soup. Okay? And then pronation, you flip them over. Supinate, pronate. Supinate, pronate. All right. Feet. I know you can't see my feet, but there's dorsiflexion and plantar flexion. So dorsiflexion, you're pointing your toe up, and then plantar flexion, you're pointing your toe down. Inversion and eversion, these are my pretend feet, okay? So inversion, you're picking your toes up and rotating your feet inwards. And then E version, you're rotating it outwards. That one's harder. Okay? Protraction and retraction of the mandible. Protract, you stick it up. And retract it, you stick it up. And then finally, opposition. So that's a finger thing. So fingers to thumbs is opposition. All right. I think those are all of them. So if we describe a movement for you on the test, make sure you can use your fancy anatomy words to explain what's going on. Okay? All right, you can have a seat. All right, that's another one that you can really impress your friends with as you're out and about. You can just explain to them all the motions they're doing. They'll be super impressed. Okay, I've got 5 minutes, maybe 4 minutes, to cover homeostatic imbalances. You ready? Yeah. Okay, the first one is osteoarthritis, the most common form of arthritis. It happens when you get older, and it's a breakdown of that articular cartilage. So just over time, the cartilage wears and tears and breaks down. Okay, so it causes lots of pain. The majority of people, if they get old, they're going to have osteoarthritis because it just happens. Okay? So what can we do about osteoarthritis? This is a picture of a knee replacement. So you've got your femur, you've got your tibia, and since it's the cartilage that's having problems, they cut off the cartilage and a little bit of the end of the bone, and they replace it with metal. Nice, smooth, shiny metal that can withstand a lot of friction. Okay, so they hammer in a piece to the femur. You can see the little rod going there. And they hammer in a piece to the tibia. So they're just replacing the cartilage in that joint with metal. Okay? Then we can also do arthroscopic surgery. So you cut just little holes and you send in a little camera and you get a little image that looks like this. In this picture you can see, it's really hard to see, but just pretend with me. You can see the jaggedness of the hyaline cartilage. So then they go in with another tool in another little hole, and they cut away the jaggedness, they smooth it up, and you end up with something that looks more like this at the end. From what I've read, they're not doing that so much anymore because it's not really helpful. Okay? It just cuts away cartilage. I mean, you're making the cartilage thinner. Okay. Rheumatoid arthritis. So rheumatoid arthritis, you don't have to be old to get it. So there are people who have rheumatoid arthritis, they're diagnosed in their 20s and 30s. It is an autoimmune disease. So your body is seeing the joint cavity and is starting to break it down. Okay? So the immune system attacks the joints. The systems begins with bilateral inflammation. So you have inflammation in both sides of your body. And inflammation just means that we have increased the fluid in the area. Okay? So blood vessels have dilated, the walls of the blood vessels have become thin, and we're losing fluid to that joint. Okay, so it becomes swollen and red. We also, in that fluid, have macrophages and things that are going to come out and eat, and they start eating away at the joint cavity. Okay? It also often leads to deformities of those joints because they're just broken down. They don't have the structure there to hold them together that they did before. Treatment for this are immunosuppressants, so you turn down the immune system in that person, which prevents the body from attacking itself, but it also prevents the body from attacking bad things. So they're more likely to get sick from viruses and bacteria and things like that. And last one, I know that we're at the end. Gouty arthritis, you might have also heard it called gout. It is hereditary. The inflammation is caused by a deposition of uric crystals or uric acid crystals in the joint. They're these long, spiky, crystally things, which then causes inflammation in that joint cavity. A lot of times you see it in the big toe joint right there. My dad has this. It's really painful. He gets big, red, swollen toes. It's great. So they can treat it with a drug that helps with the enzyme responsible for it. They can also control it with diet. So if you have gout, you don't need to eat a lot of red meat. Red meat causes it to flare up. They used to call it the rich man's disease because it was only the rich people that had a lot of red meat that ate it that had problems. All right. We're out of time. We are done. Have a good weekend. I will see you Monday. Study, study, study. Even if it's just a little bit with your micro. Don't wait until the last minute.